Yes,
All right.
we can hear you.
Oh, thank you so much. Good morning, everyone, to the second semester of our breakfast webinar sessions. We'll be having two talks today, and I hope everyone enjoyed their break and time spent with family in school holidays. So we've got two talks today. One is from our registrars here at UCT and talk from anatomical pathology. So the first talk will be the prostate biopsy, optimizing yield, infection, and pain. So Dr. Puli will be giving us a talk on that. Thanks.
Good morning. Welcome back. I'm Dr. Pule with UCT. I'll be giving a talk today on the prostate biopsy, optimizing yield, infection, and pain. Just to confirm, everyone can hear me, right? All right. So starting, so this is the breakdown of my presentation. I'll start off by going through the screening indications for prostate biopsy options we have for prostate biopsy, a bit of history on the ultrasound guided biopsy, and then we'll eventually get to the evidence and literature, what literature says regarding biopsies, which one is the best and which one is not. So we'll start off with some bit of background. As we all know, prostate cancer is the second most common cancer diagnosed in men. We have an estimated 1.4 million diagnosed prostate CAs in the year 2021. It accounted for about 15% of all malignancies. And it was the highest incidence was in the North and Western Europe, and the lowest was in Asia and Northern Africa. So for the purpose of this talk, we'll use the International Society of Urological Pathology grade 2 to 5 to signify clinically significant prostate cancer. Take note that this will entail the intermediate risk and high risk population when it comes to prostate CA. With the EUA guidelines, guideline recommendations, prostate biopsy should be offered to men with elevated risk of prostate cancer, with age above 50 years, and age above 45 years of age with a positive family history of prostate cancer. Men of African descent above the age of 45. We also recommend a prostate biopsy if they have an elevated risk of having it. Men carrying the BRCA2 mutations from the age of 40, we also recommend a prostate biopsy. So indications for prostate biopsy, they are age-related values, PSA density, which is higher than the expected, an abnormal DRE. We also recommend prostate biopsy. Imaging, if you find any lesion that is suspicious for malignancy on MRI or ultrasound, then we advocate for biopsy. After a patient has had a negative biopsy, we can do another biopsy if the PSA keeps on increasing despite the negative biopsy before. So, and also after a positive biopsy, we can redo or we can rebiopsy the patient as part of the active surveillance for low risk prostate CA. So when it comes to the types of prostate biopsies, we have the transrectal biopsy, and then we have the transperineal biopsy, of which we have the grid and the precision point device. We have the MRI cognitive biopsy, the in-bore MRI guided biopsy, which is done in the magnet. And then we have the fusion biopsy, of which uses a software. It's quite prone to errors, but it's one of the best. So a bit of background on the ultrasound. It was first used ultrasound has always been around, even during World War II, but it was first used for clinical reasons in 1956, mostly obstetric. And then it was first used in urology to visualize the prostate in the year around 1960 by Dr. Watanabe. Yeah. And then in the mid 1980s, they introduced the 7 megahertz ultrasound probe that was used that has been used since to date for standard diagnostic reasons. In 2016, they introduced the 29 megahertz micro ultrasound, which has been a game changer so far as compared to its predecessor, the 7 megahertz. It provides about 300% resolution compared to its predecessors. So the transrectal ultrasound gives us very valuable information, starting with the gland size, which we will later on use to determine whether a patient should get a TURP or an open prostatectomy. It's also helpful in helping us to know about the size, the shape, margins of the prostate, hypoechoic lesions in the peripheral zone, which might be suggestive of malignancy. And along with that, a good number of other things such as calcifications, seminal vesicles, and the vas. So the ultrasound we use is mostly B mode in grayscale, which is, as I described before, shows hypoechoic lesions as malignant in the peripheral zone. And then we also have the multiparametric TRAS ultrasound, which is static B mode, and has other functional techniques along with it, including the stiffness test, angiogenesis. It has other components such as color Doppler with contrast enhancement, which they're still looking into it, but it's showing promise with regard to prostate cancer, to diagnosing or suggesting prostate cancer. The latest development is the prostate micro ultrasound, which I'll go into a bit now. So as said before, it has a 29 megahertz. It's a 29 megahertz, and it has the same, almost the similar grading to the Pirate scaling that's used in MRI. It uses primers 1 to 5. As you go up from 1 to 5, it's more suggestive of malignancy when you get to around 4 or primers 4 and primers 5. And the picture quality is really good. So just an article to show us how to, just the article to, yes, just this is an article, a multi-center perspective analysis that compared micro ultrasound to the multiparametric MRI. It suggested that with respect to factors such as sensitivity, specificity, negative predictive value, positive predictive value, it can be considered an alternative to the multiparametric MRI. So if you don't have a multiparametric MRI, it's a good alternative to think about. Even budget-wise, it's somewhat cheaper than an MRI to have. So this is just a picture of the a schematic of the prostatic ultrasound biopsy, a transperineal and a transrectal. The one at the top is the transrectal ultrasound biopsy. As you can see, I just wanted to give us a sneak idea, because we already know, but it's good to always see an idea of how it's done with regard to, as we are going to talk about infections later on. Of note is that when you do the transperineal biopsy, there is a higher chance of getting anterior lesions as compared to transrectal biopsy, which is why it's come into favor now. One of the reasons, apart from the lower infection rates, of course. So when it comes to techniques for systematic prostatic biopsy, as per the EUA guidelines of 2023, when performing a systematic biopsy only, at least 12 cores are recommended. The sampling sites should be bilaterally from the apex to the base, as far possible as you can and lateral as possible in the peripheral zone. Systemic transperineal biopsies are preferred over transrectal biopsies for detection of prostate CA. With regard to sampling, back in the day, we used to use 6 cores for transrectal ultrasound guided biopsy, but it's since been determined that it missed. It's since been found that it's been missing about 30% of clinically significant cancers. We have stopped using 6 cores. Now we have gone to 12 cores, which is the extended core. So we take about 5 to 6 cores, evenly distributed specimen from each side of the prostate. With a systematic review of 87 studies found that 12 core sampling detected 31% more cancers and was not associated with increased infection and pain. So there's another form of sampling called the saturation biopsy. So saturation biopsy is whereby we increase the number of cores per lobe. We go to 24, a total of 24 cores. So this number of cores is symmetrically distributed throughout the prostate. It should not be used as it's not advised as an initial or in native biopsy patients, as it does not offer any superior benefit to the extended core sampling. But in cases of repeat biopsy, it does have some benefit in detecting cancer. And then we have the MRI. So the MRI provides superior resolution to prostatic anatomy and potential target lesions for biopsy, especially of the anterior tumors that are not detected by the transrectal biopsy. MRI defined lesions can be targeted for biopsy in several ways. That is the cognitive biopsy, cognitive targeting, which uses MRI. Which
any act or Simon in search. Oh, the population.
All right, sorry about that. Okay, so we have a cognitive targeting whereby the MRI is used to give us anatomical information regarding the lesion, and then we do a transrectal biopsy to get to the lesion. And then we have in-bore whereby it's targeting within the magnet. The MRI is used to guide the biopsy, the prostate biopsy in real time through the magnet. And we have the MRI ultrasound fusion biopsy, which allows for the lesions to be targeted on MRI before, and then a transrectal ultrasound guided biopsy is performed with a tracking device or with software, delineating the areas of interest or the areas of concern. So how do you prepare a patient for prostate biopsy? We always start with informed consent. You tell the patient, this is what's going to happen. You're going to lie on the bed. We're going to do this and this. The possible complications include infection, bleeding, blood in the urine, stool, hematospemia, and then you also go on to give the patient antibiotics. Depending on your local institute, we give a start dose, which we'll talk about. And then with recent evidence suggests that there is no benefit to doing a cleansing enema. The evidence recommends doing a rectal pivotine iodine preparation, as has been shown to reduce chances of infection post-biopsy. With regard to positioning, you can position the patient laterally or in the lithotomy position, depending on which kind of prostate biopsy you are doing. And then you also have to take into account that prostate biopsies can be very painful, depending again on the type of prostate biopsy you are doing, and you have to give the patient analgesia in that regard, or an anesthetic in that regard. So this is a picture of our local setup, how we do it in our center. Kindly note that we have 6 containers. We do a 12-core biopsy. We have 6 containers, 2 cores per container. We don't advocate for more than 2 cores, as it causes it messes with the specimen quality. And we use lignocaine gel also That's the one in the box, and that's our guide. Yeah. So with regard to infection, the EUA guidelines recommend that we should perform a prostate biopsy using transperineal approach due to lower risks of infection. We use a routine surgical disinfection of the perineal skin for transperineal biopsy, and we use rectal cleansing with povidone iodine prior to transrectal prostate biopsy. So in that table there on the right side, there you can see that there's a higher risk of having an infection after biopsy compared to the transrectal ultrasound biopsy. So this is a schematic, a flow chart of the EUA with regard to the prostate biopsy to reduce infectious complications. So it starts off with knowing whether there's an indication for a prostate biopsy. If there is an indication for prostate biopsy, is it possible to do transperineal biopsy or not? If it is possible, good, then we can go for perineal cleansing along with prophylactic antibiotics. If it's not possible to do transperineal, then we have to do a transrectal ultrasound guided biopsy. With this, now it recommends povidone iodine rectal preparation along with antibiotic prophylaxis. So the antibiotic we use of choice, or the antibiotic we use most commonly, is a fluoroquinolone, that's Ciprobe, in our setting anyway. So if there are no contraindications, we give a start dose. One day cover doesn't have any clinical benefit, any superior benefit to a start dose. Hence why we settle for a start dose. So risk factors for fluoroquinolone resistance include having multiple comorbidities such as COPD, diabetes, foreign travel, especially to places with fluoroquinolone resistance, recent UTI, recent antibiotic coverage, especially with fluoroquinolones, being a hospital employee also predisposes you, and the presence of a catheter also predisposes you. So here's a meta-analysis that shows that commented on the infection rate after transperitoneal biopsy with or without prophylactic antibiotics. The results of this study showed that there was no significant difference in infection rates, sepsis, or readmission rates with or without antibiotics with regard to transperineal biopsy, of course. So it seems like the transperineal biopsy has it's really safe in terms of it has lower infection rates. So with regard to pain, we can go the general anesthetic route, especially for the transperineal, and also we can go local anesthetic with Ramicaine gel. We can do ultrasound guided peri-prostatic block, which is recommended. We give 10 mils of 2% lignocaine infiltrated along the apex to the base bilaterally, or we can do a perineal block plus a peri-prostatic block. Offers superior pain-killing properties, anesthetic properties compared to either one alone. So in a meta-analysis, in a systemic analysis evaluating the pain in 3 studies comparing transperineal and transrectal biopsies, it was found that the transperineal approach had significantly increased pain compared to pain compared to its counterpart, the transrectal biopsy. And it was also found that a combination of peri-prostatic and pudendal block reduced pain compared to the peri-prostatic anesthetic alone. Now we'll be looking into some of the studies to see which prostate biopsy is superior in terms of yield. First we'll be looking at this study which evaluated the transperineal versus the transrectal biopsy in a diagnosis of prostate CA. So the study found that transperineal has the same diagnostic accuracy as transrectal transrectal biopsy, and that transperineal has less fever, but was associated with way more pain than the transrectal biopsy. And then we have the 4M trial, which included 626 biopsy naive patients, all of which underwent systemic biopsy, and those who underwent and those with a positive multiparametric MRI with PADA scores of 3 to 5. So this study found that the MRI targeted biopsy and the systemic biopsy detected an equal number of ASAP grade 3 cancers, and with 11 and 12%, so the detection rate was 0.92, which is not that significant. And then we have the precision trial, which had about 500 biopsy naive patients, which were randomized to either MRI or a TRAS-guided systemic biopsy only. This study found that the detection of ASAP grade 2 cancers was higher in men assigned to the MRI arm of the study, at 38% compared to the 26% for the TRAS systemic biopsy. We also had the MRI first trial, which had 251 biopsy naive patients who underwent TRAS by an operator blinded to the multiparametric and MRI biopsy by another operator. This study found that the MRI detected more ASAP grade 3 cancers than the systemic biopsy, with detection rates of 19.9 versus the 15.1% in the systemic. So all in all, these three trials, the precision trial, MRI first trial, 4M trial, they showed that MRI biopsy is somewhat superior to the systemic biopsy in detection of ASAP grade 2 lesions. But in the setting of biopsy naive patients, the difference was not as significant. And then we have a Cochrane review in which 25 articles were analyzed, and with regard to systemic biopsy, and MRI biopsy. And it showed that higher rates of detection of ASAP grade 2 lesions in MRI biopsy than in systemic biopsy. So far evidence is leaning more towards the MRI targeted biopsy. So the MRI, so the biopsy in this analysis, the table, we see that this is from the EUA 2023 guidelines. We see that the biopsy naive patients, for biopsy naive patients, the MRI targeted biopsy plus systemic biopsy increased detection by 20% for the ASAP grade 2 and 30% for the ASAP, 30% for the ASAP grade 3 prostate CAs. And then we have it that for repeat biopsy patients, the MRI biopsy and systemic biopsy detected 40% in ASAP grade 2 patients and up to 50% in ASAP grade 3 population. The biopsy naive patients where the MRI only was done, it showed that the MRI missed about 16% of the ASAP grade 2 patients and 18% of ASAP grade 3 patients. And with regard to repeat biopsy patients, the MRI targeted biopsy only missed about 10% of ASAP grade 2 patients and 9% of ASAP grade 3 patients. And then we have the PEDCAP trial, in which 248 biopsy naive men underwent systemic, cognitive, and software biopsy. This trial showed that targeted biopsies do have higher cancer detection rates per core than systemic biopsy. And the take-home message from this trial was that the overall cancer detection was greatest, over 70%, when the targeted biopsy was combined with systemic biopsy, all in one setting. So in conclusion, is that evidence points to improved yield with MRI targeted biopsy combined with systemic biopsy as compared to other MRI or systemic biopsies alone. Of course, we don't all have MRIs where we are, so we have to work with what we have to achieve the best results. If you don't have an MRI, it might be best to also consider other factors or other sampling methods, such as the saturation method, in that regard. All right.
Yeah, thanks a lot, Dr. Pule, for an excellent talk on optimizing biopsies, outcomes, and the complications you dwelled on. You mentioned something very important, using an MRI, sorry, an ultrasound, looking at lesions and diagnosing patients with prostate cancer and obviously targeting the lesions. I think you have highlighted in the trials that there is a role of doing an MRI first. And the data that you presented does suggest that in patients who've got negative MRIs, you could omit a biopsy.
Yes.
In terms of an ultrasound, is there any role of doing an ultrasound in a patient, and then if it's negative, and you could omit a biopsy on that?
So for that question, in light of the micro ultrasound that I mentioned earlier on, the one that's comparable to the multiparametric MRI, I would say early days, but until we have more data, I wouldn't recommend, until we have more data on the micro ultrasound, which seems to be doing really well in detection of malignancies. It's not advisable to not do biopsies on an ultrasound that turns out negative.
Yeah, thanks for that. I think you're quite right. There's definitely is no evidence to look at whether you can do a micro ultrasound, and they use micro bubbles as well to look for lesions. It only helps you when you're actually doing it real time and doing a biopsy. Are there any questions on the floor? Not seeing anything on the charts. I'll ask you a last question. You did mention quite clearly that if you do an MRI and you find a lesion, there's good evidence to suggest that you should do a targeted biopsy and a systemic biopsy. Now, the question now is there still a role to include a systemic biopsy in patients that are going for a re-biopsy? Is there still a role, if you do an MRI, find a lesion, is there still a role in adding a systemic biopsy on that, or just targeted biopsy?
Thank you for the question. Yes. I would say there's still a role in doing systemic biopsy along with the targeted biopsy. As per our last slide, it did show that there is a pickup rate of about 70% with combined targeted and systemic biopsies. And you do have a greater chance of picking up on other lesions also that are not visualized on the MRI. As we did note earlier on that MRI misses some of the lesions.
Yeah, no, thanks a lot for that. I think, you know, so, I mean, I think it's quite reasonable on a repeat biopsy to just target the lesion, because the whole thing about MRI is picking up clinical significant lesions. So if the MRI is basically on repeat biopsies, you can see a lesion. The other lesions that are not macroscopically apparent on an MRI often have a good sort of biology of disease, and non-visible lesions are often non-clinical significant cancers. I think the guidelines are still not quite crazily clear on that, but I mean, I think most people reasonably omit systemic biopsy and repeat biopsy because of those reasons. But yeah, that was a great talk. Thanks so much.
Thank you.
Stop sharing. All right, we're moving over to